Thank you for the invitation and for the opportunity. So yeah, when I saw my title, "When Things Don't Stay Put," this is what I first thought. But this is not a talk about wardrobe malfunctions or getting older. This is more about managing post-fundoplication dysphagia. These are my disclosures. So dysphagia, this is difficulty swallowing, and it can be either oropharyngeal or esophageal. So oropharyngeal is more of a difficulty in initiating the swallow, whereas esophageal dysphagia is a sensation of food getting stuck in the neck or the chest. And this is different than a globus sensation. The first thing to know is that dysphagia is common in the community. It's common in prior to surgery in patients with reflux, but it's a symptom that's found frequently in the community. The prevalence is about 3%. And patients who are on proton pump inhibitors, who have heartburn or regurgitation, or have higher somatization scores are more likely to report dysphagia. And you can see the odds ratios for this symptom in the general population. These are people not necessarily seeking medical care for this problem. In one study of patients who presented for the primary symptom of dysphagia, about half those patients had non-obstructive reflux. About a third of patients with reflux have dysphagia, and as many as a half of patients who have erosive esophagitis will also endorse dysphagia. So what causes esophageal dysphagia? It can be related to esophagogastric outflow obstruction, hypervigilance, and stasis. And stasis is basically a function of bolus passage, which is determined by the balance of esophageal motility and outflow obstruction. So ineffective esophageal motility, as defined by the Chicago classification version 4.0, is defined as a normal median IRP, so a lack of esophagogastric outflow obstruction, with more than 70% ineffective swallows. You can see the definition there. It's a peristaltic break, or more than 50% of failed peristalsis, which is a DCI of less than 100. So the thing about ineffective esophageal motility is this is common. It's a heterogeneous esophageal motility disorder, which is not consistently associated with symptoms or esophageal disease. This can be a finding in patients who are normal, who have no symptoms whatsoever. We see it in our patients who have reflux very commonly. This can be related to neural or muscular factors. The point is that we're going to see this quite a bit. And so then the question becomes, should we tailor the fundoplication based on manometry findings? We know that IEM, GERD, and dysphagia coexist. We know that not all patients with GERD and IEM endorse dysphagia, and that not all dysphagia patients with GERD have IEM. Well, this question, we took a hard look at this actually in the GERD Consensus Conference, which was presented last August in Las Vegas. And as a part of this process, we reviewed the literature, we did a systematic review and meta-analysis. And so this is that analysis of trials that looked at full versus partial fundoplication, specifically in patients with ineffective esophageal motility. And you can see that the data favors doing a partial fundoplication in these people. It favors them both in terms of long-term symptom resolution and in terms of dysphagia postoperatively. So yes, you should tailor your wrap. Prevention of dysphagia is the key to managing it postoperatively, so to not have to deal with it in the first place. So appropriate evaluation prior to the index operation, choosing the appropriate procedure, we've talked about that. Once you've chosen the appropriate procedure, you got to do it right. So there's the proper fundoplication geometry. It's easy to grab the wrong part of the stomach and pull it behind the esophagus and make a wrap that's created out of the wrong portion of the stomach, that's around the stomach itself, that's too tight. So you got to have the appropriate geometry. You got to pay attention to the hiatal closure, and you want to set expectations with the patients in advance. They're going to have some dysphagia, and usually it's just dietary modification in patients that's required to get through that. The point of this colorful slide is to show that a lot of times in patients with dysphagia, we sort of blame the wrap, and there's data to look at the wrap, but the hiatus also plays a huge role. So a too tight of a hiatus can cause dysphagia pretty consistently, and this is just a pressure topography. You can see a patient with significant dysphagia on the left and without dysphagia on the right. And what this is intended to show is that the hiatus, and these are multiple patients in each of these things. This is intended to show that it's the hiatus in a lot of folks who have dysphagia that's the issue. So to start, calibrating the hiatal repair during surgery. We all sort of prescribe to the Goldilocks principle, right? So we're trying to make it not too tight, but not too loose. But my definition of not too tight and not too loose might be different than the next guy's. And so there's really a lot of art and judgment to this. There's some technologies that are out there that may be of value in objectively assessing that. We're still working through that a little bit. That's EndoFlip. I do a lot what Dr. Haskins just described, which is to do intraoperative endoscopy. You want to sort of assess whether you can easily pass the scope through the hiatal repair and the fundoplication. You want to look at the geometry of the wrap. Did you use the wrong part of the stomach? Is it too tight? All of these things can sort of assure you that at least things look good when you've left the OR, and that you feel pretty confident that things are going to empty. So EndoFlip as a technology to assess the tightness of the closure of the hiatus or the fundoplication. This is just one of a growing series of studies in the body of literature that looks at the use of this technology and the metrics that can be derived from this technology to assess how tight things are. And so what this is showing is patients who have a change in their dysphagia score. So they have more evidence of dysphagia post-fundoplication. These are the patients on the right in the red, as opposed to patients who don't have an increase in their dysphagia from pre to post-op. These patients had much greater changes in their distensibility index as the balloon was inflated. So the more fluid that was put in the balloon, the lower the index got, the tighter things were. So there's some sort of objective feedback to suggest that this technology and the data derived from it can be helpful in correlating who's got dysphagia and perhaps in preventing it. So now you've got a patient who's got post-fundoplication dysphagia. What do you do about it? So first of all, it's normal. We've talked about that. If a patient's going to have dysphagia, it depends a lot on what they're eating and how quickly they're eating. So you need to make sure that they understand what they can do to address these issues. And it usually resolves spontaneously with time. If dysphagia lasts for more than 3 months, it's called persistent dysphagia. So dysphagia in and of itself isn't a complication. It's an expected sort of side effect. But when it persists, it is an adverse outcome. And the reported rates of persistent dysphagia are anywhere from 3 to 26% in the literature. So first of all, early post-op dysphagia does not necessarily mean that this operation is going to fail. This is one particular study that grouped patients into significant early dysphagia, mild to moderate early dysphagia, and no early dysphagia, and showed that over the long term, several years post-op, the GERD outcomes were equivalent in those groups of patients. So all is not lost if your patient struggles out of the gate, and you choose to manage that conservatively. Early post-op dysphagia in a patient who's got mild to moderate dysphagia, you wait. Dietary modification, prolonged pureed or full liquid diets. Pay attention to their nutrition and their weight. You want to watch them really closely, but a lot of times this will resolve on its own. More severe dysphagia, so if the patient's having a difficult time managing their secretions, they're experiencing significant unintentional weight loss or other nutritional concerns, you might consider a course of steroids. You might dilate. When is it okay to dilate is a question that we'll touch on in a second. Make sure the repair did not fail acutely, especially if the patient felt okay for a little bit and then got much more significant dysphagia after an interval of time. That can happen. And then doing the intraoperative sort of measures that I've discussed to give yourself some assurance that things are okay will often give you the patience to wait. Steroids for early post-op dysphagia. So this is a practice that I've used for years. We do dexamethasone 4 milligrams twice a day for 5 days. This is based on the assumption that swelling and inflammation is the cause of dysphagia in some people. It's a common practice. There's really no literature on this. I tried to look it up, and there's literally nothing published. Anecdotally, it can help. Again, you need to make sure there's no esophageal obstruction. This is just a little snippet from a SAGE's Foregut Surgery symposium post about a patient with this sort of a scenario. And I put this up there because if you follow this thread, there's a wide variety of opinions and approaches to a patient with this sort of issue. Steroids is endorsed, steroids are vilified. Dilation, you can't dilate early. You should take the patient to the OR right away. You should wait. A lot of different opinions, a lot of different approaches. Dilation for dysphagia. Uncontrolled trials have a success rate of about 50 to 65%. There's one randomized controlled trial looking at balloon dilation versus sham dilation in patients with dysphagia, and really showed that there was no difference in this randomized trial. The issues with this trial, however, are that these were patients with functional dysphagia. They didn't have elevated IRPs. There was no stasis on time-barium esophagram. So I think it's a reasonable thing to try. I personally would offer it early if I needed to, but obviously I'd prefer not to. And then early reoperation. If a patient's ability to manage their secretions or swallow is impaired immediately, concerns about an overly tight hiatus or impaired motility pre-op exist, and you're going to reoperate as your approach, I'll remove the hiatal sutures. I'll do intraoperative endoflip. I'll assess the distensibility at the beginning. I'll take some sutures out. I do a lot of toupees in the first place, but if the patient's had a Nissen, you might consider converting them to a toupee in that setting. And in a lot of these folks, I'll place a peg, just so that you've got something to fall back on if they struggle postoperatively. Evaluation of persistent post-fundal dysphagia, so the patient's out a little bit further. They're really struggling. Endoscopy and esophagram are essential tools. Evaluate for slipped or malpositioned fundoplication. Assess the degree of esophageal obstruction and stasis. High-resolution manometry is critical in these patients. You'll see esophagogastric outflow obstruction. There's things you can do to try and discern whether it's the hiatus in the diaphragm or the fundo that's causing the elevated EGJ or IRP. But in the end, you're going to go look at both of those issues and most likely convert the patient, if they're a Nissen, to a toupee. This is what an endoscopy might look like. It sort of shows you why this is helpful. You can see these slipped and these malplaced fundoplications associated with patients with dysphagia, so a critical part of the assessment. And then reoperation, there's several series out here. I put this up here to highlight the fact that in this particular study with 25 patients, Nissen to toupee, the outcomes were great as it relates to resolution of dysphagia. And again, if you're there, you don't want to keep going back. You have limited opportunities to go in. So address everything that you can. Make sure the hiatus has been assessed. Understand that when you close it, it might scar down and get even tighter. And make sure that you've created a situation where you've given that patient the best chance to succeed without potentially having to go back again. So in conclusion, dysphagia and reflux often coexist. IEM doesn't always correlate with symptoms. Toupee has less risk for persistent dysphagia than a Nissen. Post-fundoplication dysphagia usually resolves with time, and severe cases may require early intervention. So with that, I want to thank you guys for the opportunity.